serve as moderator for this third and final panel, which will be on access to health and justice. And before I introduce the panelists, I would just like to remind you all that it would be wonderful if you would stay afterwards to attend the Hot Topics open mic session from 5 to 5:15, and definitely the reception. That'll just give us an opportunity to get to know more of you a little bit, continue to talk about our work, and it would just be great if you all could hang around for that. Thank you. We're going to hear from Dr. Jenny Klugman and Matthew Moore. Dr. Klugman is the Managing Director of the Georgetown Institute for Women, Peace, and Security, and Matthew Moore is the Hillary Rodham Clinton Law Fellow, also at the Georgetown Institute for Women, Peace, and Security. And their talk will be on intimate partner violence, enabling access to justice in conflict-affected states. And then following, we will hear from Dr. Jennifer Bowie, who is an associate professor in the Department of International Health at the School of Nursing and Health Studies. And Dr. Bowie's presentation will be on barriers to health care access and utilization among low-income, high-risk transgendered individuals in the United States. And this will be a systematic literature review. And finally, we will hear from Sonia Franconi, who is a medical student here at Georgetown, and she will be presenting on telemedicine and teen access to contraception. I will be the timekeeper, so I'll sit here and let you all know when you're 5 minutes, 2 minutes, 1 minute, and time to stop. And thank you all for being here, and we'll start off with our first presentation.
Okay, thank you, and it's very nice to be here this afternoon. I feel now I'm part of a tradition since I participated last year as well. Although I must apologise in advance, I got off an aeroplane came directly from Tanzania this morning, so I think I'll be okay. I should make it through the hot mic. I'll have a drink and then I'll go collapse. But you'll be pleased to know I did have a shower at the office when I arrived from the airport, so I'm at least well washed. So what I'm going to present this afternoon is actually work that Matt has begun in earnest since he joined our team about 2 months ago. It's something on which I've been working for some time. I'm coming at this more as an economist, although I do have a background as well in law, focused very much around issues on gender equality in developing countries, and that'll be the focus of what we'll be highlighting this afternoon. The reference here to conflict-affected states is the set of countries as defined by the World Bank as being affected by conflict. So they're either in conflict or post-conflict, and there's a smaller group of countries which are known as fragile. So oftentimes you'll see reference to fragile and conflict-affected states. They number about 36 in total. Half of which are in sub-Saharan Africa, a number in Middle East, North Africa, and South Asia, Afghanistan, for example. You'll see some of the examples as I go through. But just to clarify that at the outset. What we were going to talk about this afternoon was just to give a little bit of a background in terms of definitions, although I'm sure that this is increasingly familiar to you in terms of what we mean when we talk about intimate partner violence, the framework governing the treatment of such violence at the international level, a little bit about the empirics, but then focus much more on what's happening in conflict-affected states where I think much less is known, in part because of lack of data up until relatively recently. And we do want to have a focus on promising directions in terms of interventions and in particular the role of law. So in terms of the kind of the big picture, I think many of you would know that intimate partner violence is that inflicted by an intimate partner, a boyfriend, spouse. It not only includes physical and sexual violence, but also emotional and financial abuse. And the headline figure around the world for the share of women who have experienced such violence in their lifetimes is about 1 in 3. So a very large share of women have experienced this in their lifetime. And in that context, the international legal framework has become much clearer over the last, I would say, in particular, decade. So if you look back at, for example, the Convention for the Elimination of All Forms of Discrimination Against Women in 1989, there was no specific kind of definitions and so on around intimate partner violence in that convention, which has now been signed up to by nearly all states except the US. But over the period since then, through declarations at the United Nations, through work that's been done by WHO and others, there's been, if you like, a solidification of what's understood by intimate partner violence in terms of its definition, the responsibility on states to adopt frameworks prohibiting such violence, and of course declaring such violence to be a violation of human rights. But then when we look at the scale, as I mentioned, the kind of the headline figure for around the world is 1 in 3. The rates that we show here in this graph is from, oh, I've got a different one here. Is this the lifetime one, Matt, or this is the 12-month? This is 12. Yeah, so this is presenting past year experience of violence. So obviously the figures are a bit lower than 1 in 3, but still very high in a number of states. But I think the point that I want to underline here is that whilst there is regional variation, so the average, for example, is highest in sub-Saharan Africa, there's an enormous amount of variation within regions and within country groups. And so understanding what drives those differences and the role of law in particular in terms of promoting change, including in norms around violence, is an important question that we're exploring in this work. And then just to give you a bit more of a drill down on what's happening in fragile and conflict-affected states, we don't have data for all of the countries, but we do have reliable survey data for a fair number. And just underlining here, we don't here use reported rates. So it's not the numbers of women who are going to the police or to the authorities with reports of violence. This is based on population surveys where the confidentiality is assured, certain protocols are followed, and you get much, much higher rates than you would get from criminal reporting. But you can see here, maybe difficult to read at the back, but this again is annual rates of violence, very high in Afghanistan, Timor-Leste, the Solomon Islands. The Pacific in general reports very high rates of violence, but a number of post-conflict countries as well, including Liberia. So I'll turn over to Matt now, who'll talk about why we might expect to see high rates of violence in countries which are affected by societal violence and what's being done to address that. Matt.
Okay. Hi, everybody. Thank you, Jenny. I wanted to thank the organizers and especially Jenny for coming back from Tanzania this morning and joining the panel. So as Jenny explained, I'm going to be speaking about what we know about IPV or intimate partner violence in conflict, and which is because the data is scarce, what we know is still emerging, and then talk about what we know about what to do about it. So legal reform. So growing body of research shows that there is a link between intimate partner violence and conflict. So we know that high intimate partner violence is prevalent in conflict-affected states. A really recent study showed that in Liberia, in conflict-affected districts, there was a 50% higher risk of intimate partner violence, so a significantly higher risk. And similar research has been done in Colombia, along the Thai-Myanmar border, and in a number of other fragile and conflict-affected states. So we know that there is this link, and it's still emerging in the literature, but one thing we're going to look at in the research is what are some of the reasons for these elevated rates of intimate partner violence. So reasons for this link include increased acceptance of violence as a conflict resolution method, economic hardship, associated alcohol use, which is highly correlated with intimate partner violence, and male depression, and the breakdown of the justice system. So especially when legal institutions don't work, we know that there is very little access to justice for victims of intimate partner violence, which is very common in conflict-affected states. So what are our thoughts about what might be done about this? So as I said, we're focusing on legal reform, although that's one piece of the puzzle, but we think it is a very important part of this puzzle. And you may be wondering, and I think it's a theme that has come up in a number of the presentations this afternoon, but do laws matter in this context? Can laws really make a difference? And that's clearly a very important question. My first answer to this is that I hope they do, because I just went to law school. So it would be good if they do play some role here. And our research shows that they, in fact, do impact levels of violence in countries that have this kind of legislation. So even though rates vary, even in countries that have domestic violence legislation, we found that the rate is on average 5% lower if countries have these laws. So laws do matter. We also know that there's a major gap in legal protection for countries that are fragile or in conflict. So it's probably unsurprising, but countries that are in conflict often don't have legal systems that are functioning very well. So to date, 144 countries roughly have passed domestic violence legislation, but only nearly two-thirds of conflict states have no law whatsoever on domestic violence. So we know both that there are elevated rates of intimate partner violence and that legal protection is very low. What this graph shows is also that where fragile and conflict states have these laws, they've enacted them fairly recently. So really it's been a recent wave of laws in the past decade or so. So there's also very little data about exactly how these laws are working, but it's been very recent. So an example of one conflict state that has tried to respond to the problem of intimate partner violence is Afghanistan, which has one of the highest rates of intimate partner violence worldwide at 46%. And Afghanistan passed a law in 2009 requiring the government to investigate and to prosecute where appropriate cases of intimate partner violence and other cases of violence against women. But we've found that in the vast majority of cases, the formal legal system still doesn't take the cases, or they go to informal mediation. And in Afghanistan, at least, often when cases don't go to the formal legal system, the resolution is not very favorable from a perspective of women's rights and victims' rights. So often victims will be pressured basically to go back into the house in which the act was perpetrated. So Afghanistan shows that states are passing these laws, but there's an implementation problem, that if states don't properly implement them, then they may not be doing a lot of good. Liberia is a second example. It's another country that, of course, is still feeling the legacy of conflict and that has a high rate of intimate partner violence at about 35 or 36%. And in Liberia, they've established a special court which hears cases exclusively of gender-based violence and rape. So this is an effort to deal with the problem of violence against women. And again, what we found is that this court, while it does resolve some cases, the rate of the number of cases it resolves is pretty low. So it only has one judge, which precludes it from hearing very many cases, as you might imagine. They also have what's called the peace huts, which is an informal mechanism of committees of women that mediate cases of local disputes and often cases of domestic violence. And these have been even more successful in resolving a high number of cases of violence against women. I think it was something like 250 cases in a year, which is a lot more than the formal legal system resolves. So some implications for policy for this. One, we know or we believe that states should enact legislation on domestic violence. It's not alone sufficient, but it does send a signal that certain conduct is not acceptable, and it also can help change norms in terms of whether people believe violence is an acceptable means of conflict resolution. The law should also ensure that there are civil remedies, so protection orders can be a useful way to shield victims in fragile and conflict settings, just as here. Also, 24-hour courts and mobile van courts should be established. These are tools that have been used in places like the DRC, where to reach rural and conflict-affected populations, innovative mechanisms are needed to really give them access to the justice system. States should implement human rights treaties like CEDAW. These treaties set a baseline for what is violence. They define intimate partner violence and domestic violence, and set a common standard for human rights. Finally, as both the Afghanistan example and the Liberia example show, states should engage in formal systems of justice. So that can be both a helpful thing and a less than helpful thing. It's in the case of the peace huts in Liberia, we've seen a lot of success in resolving disputes and in a way that's satisfactory to victims. So our research is going to be looking at all of these connections and ways for states that may not have functioning justice systems to address the issue of intimate partner violence and hopefully do something about this problem. So, thank you.
Hi, everyone. Let me see. Okay, there we go. Yes, I'm just trying to adjust to the system. So I'm Jennifer Bowie from Global Health, International Health from School of Nursing and Health Studies. Really want to thank the Gender Justice Initiative to invite me to give this talk. Feel very privileged to be here, and thank you for being here. Let's see. Yeah, so today's talk, I would like to talk about health services utilization, barriers to the access to healthcare among the transgender women who are also sex workers. And I'm going to bring you back to the US. So this is a study specifically targeting US research on this topic. So a little bit background. The reason I started this is because I was writing a proposal, right? Writing a proposal on a HIV prevention among the transgender sex workers in the United States. At the time, I just had done many years of study in China, doing HIV prevention among the migrant, rural to urban migrants and female sex workers. And then when I bring this study to the US, to our backyard in DC, I found there's so little literature on this. And it confirmed lots of our assumption that in the US it's actually harder to conduct studies among sex workers. But in any case, we conducted study. And looking at the literature, in the same year, we found that DC actually gave a survey among the transgender persons. And in that survey, more than half of the transgender women reported in the past or currently they're engaged in sex work on the street. This compared to 16% in a national survey of transgender women. So that also got our attention. So finally, we also see a lot of health issues among transgender women. 60% consider suicide, drug abuse rate is very high, and 21% in HIV positive. So all of these are really dangerous signs. So these are the backgrounds of this study. So what we want to do as a result is to systematically review the literature on the health conditions and health barriers for healthcare access among transgender women who engage in sex work. Okay. So we used a very traditional literature review, systematic literature review process, and looked at multiple database, and we used multiple keywords in a combination of transgender terminologies and health services terminologies, as well as some of the risk factors we suspect that will be appear in the health services barriers. And we had recruited several students. We have a research team of 4, and then look through all the abstracts and the full text articles. And this is a chart that's showing that how we narrow down the articles from thousands to at the end is only 39. The inclusion criteria for this study include that it has to be US-based, it has to be primary or secondary research, it has to be focusing on transgender women population, and we only limited these 39 that they have to mention sex work in their research. So those are the main inclusion criteria. So overall, we found among these 39 studies, first of all, many of them are in recent years. So there's not a surprise to us that there's more research on transgender women in the recent years. Actually, the MASH word, that's the medical subject keywords that used by the National Medical Library, only established transgender person in 2016. So their database only go back to 2013. That's why we have to do a lot more individual search. We cannot just use that category. And most of these studies were targeting this very highly marginalized, highly stigmatized group. So not surprisingly, it's mostly in the urban areas, and the recruitment are through community organizations or at the events or at some of the clinics. And then in terms of the finding, I'll talk a little bit about the social demographic characteristic of this group. And then I'll move on to transphobia, how they feel about transphobia from different sources. And I also talk about why sex work is so high, engaging in sex work is so high in this population. And finally, I'll talk a little bit more about the health services barriers. So first of all, social demographics. It's not surprising that many of these transgender female sex workers, they are low income and very high unemployment rate. So that's actually one of the most common theme here is the difficulty to get a formal job. Housing is an issue. Many of them, 27 to 70% that's the rate reported in different reports, in different research reports on the unstable housing in this population. And when they're in this condition of unstable housing, they listed living on the street, living on the hotel, in the hotels, in the drug treatment centers, in shelters, and many different conditions. And actually that later on in our work in DC, we found that unstable housing is a critical determinant of sex work because when you don't have your own place, often you have to stay in someone else's place, and sometimes sex work start to be the only thing that you can put in that situation. And finally, incarceration. Incarceration has often been mentioned by this population, but there's actually no research specifically looking at how incarceration, in fact, have impact on healthcare services. But incarceration in this population often relates to sex work and sometimes relates to the drug abuse. All right. So why sex work is so high in this group? We have already talked about the job situation is very difficult in this group. So one of the quotes that's actually in the next slides. I can't see it. So, okay, I can't see that either. I'm guessing where I am. All right. So here I'm just talking about. There's very few articles looking at sex work among transgender women, even though it's very common. Only 6 of them specifically talk about sex work. 19 of them refer to some of the sex work among the transgender women. But we did find that percentage of Latinas and African American and foreign-born transgenders are more likely to report engaging in sex work. And now here's my quote. Here's the quote is that there's not, so we're not offered specific job training and we're discriminated against for our physical appearance. We do not have many options, and many of us want to get out of the street, and it is almost impossible. So I thought this is one of the typical quotes talking about the job opportunity, job-related training and education that's so much lacking in this population. And then the second reason, I think, is related to some kind of the gender-affirming process. And this is talking about, well, first of all, it is fast, easy, and financially rewarding process for many of the transgenders to get additional resources for hormones, gender surgeries, drugs, and other necessities. But also, in a way, they feel that if they are being a woman on the street and being accepted by men as a woman, that's a gender-affirming process for them. So then you'll see that they see this as a rite of passage almost, and some of the older transgender women will serve as a mommy role there and introduce the younger ones to the clients. So in a way, this is especially for some minority groups, these are pretty much the common practice. All right, so harassment, transphobia. So we concluded that there are 3 main sources. One is from police. I think that the problem with the transphobia from police mainly affects the sense of safety of these women. So when they are on the street, they are experiencing violence. When they report to the police usually don't pay the same amount of attention like with other women. So that seems to be the one of the problem. The other one is from clients. So often they want to hide their own identity from the clients. So that also increases a lot of fear and not reporting of the violence that they experience. So that's the second source. And the third is from family, and many of them reported being ridiculed and being pushed out of the street, out to the street, and not being accepted by the family. Okay, and healthcare services. So many of them talked about the specific healthcare services that they need that's not included in the regular insurance settings. So things like hormones or some of these supplies are usually not included. I'm trying to be raised a little bit so that we can fit the time frame. And transphobia apparently also comes into this health services access issues. And I think this slide shows more of what's their intimidation. But when they're confronting the healthcare system, often when they get to the hospital, they feel that their identity get more attention than their illness. So they said, every time we go there, we have to educate the doctor that, yes, we are transgenders and we have these issues. But often their illness is not being considered as serious compared to sort of the mental health. right? And many of these studies are sponsored by HIV research. So that's we actually got quite a few quotes on HIV testing barriers. They are similar to the barriers that they encountered in the general health care, but I listed some of the specific problems, like the fear of the stigmatization from the testing counselor, and whether they are afraid of confidentiality issues, that their identity can be leaked. Okay, so other than healthcare, we also look at all these different other social services that needed by the transgender women. So I listed here. So as a conclusion, what we found here is that first of all, there's not then that much research focusing on the transgender women, especially those engaged in sex work. And to do that, we first of all need to have definitely more interest in this population, but also we need to have engagement, research engagement with the community of these population, so that we can gain their trust and then engage them in the research. So I see that's the first step. And in my DC sex worker study, I have half of my study participants as the cis, we call cis sex workers, and half of them are transgender sex workers. They're very, very different in terms of their risk factor profiles and the intervention tracks. But I think that the key to us is how to engage to the different community. And also, some of the healthcare settings, how to improve the communications between the primary care physicians with transgender sex workers. What is the proper way for the physician to ask about sex work on the street, right? Now, especially for HIV, we have PrEP, which is highly effective, has been proved to be highly effective among some high-risk group. But so far in the U.S., only Caucasian gay community has embraced it. The African American women has low take-up rate, so is the transgender women. And finally, I think eventually is for the whole society, how should we do in the school, in the community, to provide a supportive environment for transgender women. Okay, I'll end that.
Good afternoon, everyone. My name is Sonia Franconi. I'm currently a first-year medical student here at Georgetown. I'm really grateful for the opportunity to be here today and just share with you the topic of telemedicine policies for contraceptive and abortion care. It's a really important topic. Actually, it's very, very pressing to talk about this. Just this morning, I read an article about how there's a group in Kansas who is currently suing the Kansas state government because they're trying to enact a law that forbids telemedicine to be a platform for which abortion services can be rendered. So let's begin. First, contraception is defined as just a method that will reduce the risk of unwanted pregnancy. There's a lot of different methods of contraception. The most common is the birth control pill. The second most common is the surgical procedure for sterilization, and it's more common for women to do this than for men. Third most common is condoms or long-acting range contraceptions. Abortion is defined as the termination of a pregnancy. And as you can see, there's a very large percentage of pregnancies in teenagers that are unintended, so it's very important that they have access to contraception. One of the reasons why it's so important for teenagers to have access for contraception is because statistics show that only about 50% of teenagers who experience teenage pregnancy will get their high school diploma by age 22, as opposed to about 90% of minors who do not experience a teenage pregnancy will be able to get their high school diploma. And as we know, our ability to establish a financial security and get a good job in the workforce really ties back to our educational status. So it's important that minors get contraception so that they're able to reduce the risk of this unwanted pregnancy that could have adverse effects on their educational status. There's a lot of barriers to contraceptive care for minors. I want to specifically talk about state-specific policies and provider reluctance. State-specific policies, basically every state has their own kind of recipe for what is allowed and what is not allowed for contraceptive services. And the thing is that a lot of these laws are very obscure and complex, which makes it very difficult and confusing for physicians to be able to interpret what these laws are saying. As a result, it makes an environment of the physician being kind of reluctant to engage in these kinds of services. In addition to all of these barriers, there's also a concern for confidentiality. So in a study done by the CDC, they found that, I'm trying to see the numbers too, between 15 to 17-year-olds, there was a very large percentage of them that they stated that they were afraid to seek their physician to talk about sexual and health reproductive services because they were afraid that their parents would find out. And as the age increases, so we can see 23 to 25-year-olds, a little under 2% still express a concern that their parents will find out that they will go to their doctor to talk about contraceptive services. On the right-hand side, we see a graph that is showing the percentage of minors 15 to 17 who actually get some time alone with their physician. So we can see that as the age increases, again, we get a little bit more time alone, but there's still very few minors that are getting one-on-one time with their physician. And probably something that has to do with this is transportation. In most states, 15-year-olds are not allowed to have a driver's license. So what will happen is that their parent will go with them to the doctor, and usually that will result in the parent accompanying their daughter into the exam room. So some access to contraception, as I mentioned, it varies by state. 26 states and the District of Columbia allow minors 12 and older to obtain contraception, whereas 20 states, they have a little bit more stringent qualifications. So for example, Florida, if you're a minor who wants contraception, you will either have to be married or have given birth before, or there has to be a medical reason for why your doctor needs to prescribe contraception. And this medical reason, it's really left up to interpretation. So for example, some doctors might want to treat acne with birth control, so they'll prescribe the birth control under the treatment of acne. But other doctors, they'll need more than just acne. They'll have to have medical reason to believe that this minor needs contraception, otherwise the pregnancy could be life-threatening. And as you see, there's 4 states that actually have nothing on the books about this. This is a map distribution showing the numbers that I just described. So the blue states are states where minors can explicitly get contraception from their physicians. The language around the law is very intentional, it's very clear, there's no like blurry lines about whether a doctor can prescribe contraception. The pink states are states where there's an age criteria, and even among the age criteria, there's also diversity. So for example, in most states, as long as you're 12 years old or above, you can consent to getting contraception, but in South Carolina, you have to be at least 15 or 16 years old. The brown states are states where you're allowed to get to consent to contraception if you're a minor, but your parent will be notified. So this might seem like, well, what is the issue here? Because at least the minor is able to say to consent and receive the contraception. But in some cases, when the minor then goes home, she might get disowned from her family, or she might be at risk of losing her home. And the green states are the states that, again, there's nothing on the books about it. So I want to transition now to talking about abortion in minors. As you can see, there's about 350,000 pregnancies per year in minors, and this pie chart is showing the distribution of what will happen during that course of the pregnancy. So about 60% of pregnancies in minors will be carried to term, 12% result in a miscarriage, and 28% have an elective abortion. And breaking the elective abortion down further, only about a third of these elected abortions are medically induced abortions. So you might have heard about the abortion pill. That's what that means. And still about 2/3 are surgical abortions, which it's the DNC procedure, the dilation and curettage procedure. So minors accessing abortion, you can already tell that there's a lot more diversity in how states will handle abortion in minors. 2 states and the District of Columbia are very explicit. They say, yes, if you're a minor, you can consent to your abortion. 21 states require at least one parent to provide consent. 11 states require at least one parent to be notified. And the reason why we see at least one parent is to account for households where the parents are divorced. 5 states require both notification and consent, and 6 states, they have, they're currently enjoined, and I'll come back to what that means. And 5 states, there's nothing. Similar to contraception, there's also 5 states here where there's just nothing on the books about minors consenting to abortion. So here's our US map, again showing the numbers I just described to you. So I mentioned that I would come back to what it means to be enjoined, and I think our friends from the law school in the audience might be able to explain this a little better, but from my understanding, if the law says that either the parental consent or the notice clause is enjoined, it means that whatever process was underway is currently stopped, and this can either result in one of 2 things. So for abortion, if the parental consent portion of the process was enjoined, then that means that either the abortion is terminated, or it could mean that the minor is forced to carry the pregnancy to term. And there's a lot of barriers to abortion care. Of course, parental consent remains a huge barrier, and also judicial bypass. So what this means is that if the minor would like an abortion, but there's just no way that her parents can consent, there's no way that they can be notified, what she can do is, as a minor, find a lawyer, pay for a lawyer, and then set up a court appointment with her lawyer in order to discuss with the judge about her circumstances, and then the judge will make a decision based on what he or she has heard about whether this minor can get a judicial bypass and go on with her abortion without her parents having to provide consent or be notified. For ultrasound and weight requirements, in some states, after you receive your initial ultrasound, you have to wait from 24 to 48 hours before you can actually get your abortion procedure. And in some states, there are burial laws. So you might be surprised to hear that in some states, they require the minor to pay for a funeral service for the aborted fetus or whatever tissue is left from the miscarriage. And there's also, of course, cost and insurance coverage. Insurance is always a way to bring parents into the loop via the explanation of benefits. So there's a matter of confidentiality there too. And transportation. Depending on where you live in the United States, you can either be within 15 miles of an abortion clinic, or you can be more than 180 miles away. So telemedicine, could this be a solution to abortion and contraceptive services for minors? So telemedicine can be defined as just the virtual exchange of information between the patient and the healthcare provider. In 2017, 50 million Americans actually said that they would prefer telemedicine services for chronic and urgent conditions, and you can see there's about an equal percentage of physicians who are willing to provide this service. And cost, access, and quality, these are the 3 pillars by which we analyze whether a healthcare system is doing what it should be doing. So for cost, is it affordable? For access, do minors have access to a computer and to internet? And for quality, I'll come back to that. That has to do with the patient-physician relationship. So similar to contraception and abortion, each state has their own telemedicine policies. Depending on the state, they can either be real-time, store and forward, or audio-video data. real time just means it's kind of like a FaceTime conversation with your doctor. Store and forward, this was actually started in nursing homes, and basically what it means is that the nurse would take a video of the residents there and then forward the video to their doctor, who would watch it and then decide based on the video what treatment changes needed to be done for certain patients. There's several levels of encryption on audio-video data in order to protect the exchange of healthcare information. This is a US map showing the states that allow telemedicine. So the blue states are states where telemedicine is allowed, and the pale blue states are states where there's nothing on the books about telemedicine either. So you might be surprised to hear that telemedicine is actually something that's happening here at Georgetown, and it's becoming something that's more and more popular. These are some patient testimonials you can read, particularly the one in the middle, where there's somebody saying that the care I received was equally as good as any care at an in-person visit. So it goes to show that this really is something that is rising. And minors accessing telemedicine, again, there's the issue of payment. Insurance, again, brings parents into the loop. There's an issue of consent. In order to begin telemedicine services, does the doctor need oral, written, or digital consent? And the patient-physician relationship. So in some states, they'll allow the patient-physician relationship to develop over the course of the telemedicine treatment. In other states, it requires at least one in-person visit before you can actually start telemedicine services. And this is an article that I read from the FTC. It has nothing to do with abortion or contraception, but I just want to make a point of how the way that we get parental consent is evolving. Nowadays, it's okay for the parent to just get like a selfie of themselves holding their valid ID, like a driver's license or a passport. And then, again, you can tell I really like maps. So these are side-by-side maps showing states where either there's contraception allowed but no telemedicine, and then states where there's telemedicine but no contraception. Telemedicine would be a way to bridge a lot of the barriers that we see with abortion and contraceptive services. For example, it would eliminate the need for transportation, and it might even increase the one-on-one time that the patient, the minor, can obtain with her physician. This is a photo from a website called Aid Access. You guys might have heard. There's actually a website that if you're a minor and you need abortion pills, you can go online and type in, there's like a request form, and you explain your situation, you explain how far along you are, and it's sent to the founding physician. She will read your request, and she's going to decide whether it's appropriate for you to receive these abortion pills. Usually if it's in the first 10 weeks of pregnancy. And if the founding physician decides, yes, we can go ahead and do this, then abortion pills are mailed to the address that the minor will provide on the initially requesting form. So in summary, contraception access and abortion access are restricted for minors in many states and territories in the United States. Telemedicine policies vary widely across states, and in some jurisdictions, telemedicine can improve access for contraception, going back to the transportation barrier and getting more one-on-one time with the physician. And telemedicine is not established yet as a solution, but it is rising. These are my references. I'd like to acknowledge my mentor, Dr. Graves. She's currently on a flight on her way to an APHA conference, but I'm really grateful again to be here. She's always helping me find professional development opportunities, and I'm really grateful for her as my mentor.
Well, let's start off by thanking our panelists for excellent presentations, and particularly for doing work that is important to us all, but also work that is important to us at the Gender Justice Initiative, work that we support and that we promote and that we encourage. So thank you all for excellent presentations and the work that you're doing. Please join me in offering a round of applause. Okay, so we would like to open up the floor for questions. I hope you all have jotted down some excellent questions for our panelists. Yes, there's one here.
Thank you. This is for Dr. Bowie. I was wondering if you came across any studies that show a difference in healthcare access when sex work is decriminalized. So I know you primarily focused on the United States, but if generally in your research there are big differences.
Hello? Yeah. Good question. I primarily, my research were in both China and U.S. Both countries are criminalize the sex workers in a little bit different ways, but in many ways on the surface is the same. We did a study back a few years back looking at different countries' approach to sex work and public health in the sex work and the public health arena. So we compared India, which is the sex work is legal, Singapore, where sex work is legal only in certain zone, and of course China and U.S., where sex work is illegal. So I think, from public health perspective, it's definitely much easier to provide occupational health to sex workers. So providing HIV, STD testing, providing prevention of certain diseases, those are all much easier to conduct in the countries that is legal. But in terms of violence, stigmatism, those are actually, we didn't see a lot of differences among these countries. Even we have a case study in India when it's, sex worker can go on street to demonstrate, but still they're treated very poorly by the police, by their family, and by the many of the caste system in the society. Many of their kids cannot go to the schools that for regular kids. So I would say, yes, from public health perspective, it's helpful. But in terms of the societal phobia and marginalized population, that still have a long way to go.
Thank you so much. Sonia, I just cannot help but say that it is so wonderful to hear about somebody at the Georgetown Medical School doing work on access to abortion services. So, yay you. Sorry, that's just a comment. But my question is really for Jenny and Matt. Your paper looks at these complicated relationships, countrywide issues and intimate partner violence. And I wonder if some of them, if the relationships are not causal one way, but causal in two ways. So what I'm thinking about is, you're talking about how countries involved in conflict have higher rates of IPV. Is it also true that countries with higher rates of IPV have higher rates of conflict, and countries, I hate to burst the bubble of laws work, but if countries with laws about IPV have lower rates of domestic violence, is it also true that where they're in countries where there are lower rates to begin with, they're more likely to adopt those laws? How complicated are those relationships?
Well, I'd added a note at the bottom of one of the slides on the causality, because I think it does go both ways. In particular, there's a body of work which looks at different measures of gender inequality, including rates of intimate partner violence, and shows that those are correlated with higher rates of societal violence for the same sorts of reasons around the normalisation of violence as a means of resolving conflicts and so on. And so there's work by Valerie Hudson, Mary Caprioli, and I've been doing some work on that as well, updating to show how adverse gender norms and in particular behaviours around violence against women in the home is associated with higher rates of violence in the society. So that's certainly true. At the same time, the studies which show that the rates are higher in fragile and conflict-affected states, I think, is still a robust kind of overall finding for the sorts of reasons that Matt outlined around kind of breakdown of norms, disruption, economic stress, alcoholism, depression. They're all things that we would expect in any society, to have adverse implications for violence in the home as well. So I don't think they're mutually exclusive, but it points to the importance of careful work. And then on the other... on the effect of laws. I guess the way we try and control for that, it's certainly true that you would expect that countries that have more supportive norms towards gender equality would be early adopters, if you like, of intimate partner violence legislation. At the same time, what we did, not in that study there, but in another one, we actually controlled for the number of years that the legislation had been in place, and actually that seems to make a difference. And so that's an interesting finding in the sense that it may be a more positive environment initially, but then the passage of time is something which, if you like, changes the norms and makes it more, if you like, adverse to the acceptance of violence. So, clearly there is some relationship, but at the same time, I think that it's suggestive. But we're not going beyond saying it's a piece of the puzzle, and certainly there are examples from earlier sessions as well about FGM and kind of other practices which are prohibited in law, which, can be very pervasive in a society.
And I would just add, I think that's a great question because the relationship is so complex. But one thing I didn't mention was that in countries with ongoing conflicts with high levels of casualties, we've seen that there really are no laws on domestic violence, or that legal systems may be really totally absent. So one way to look at it is that it's a complex relationship, but it is a baseline that having laws at least sends a signal that it's not acceptable.
A question here.
Hi, thank you so much for your presentations. I had two questions. One was for the first presentation. I thought what you were talking about with the peace huts was really interesting, and you said that they were really effective, and it seems like a really interesting, culturally sensitive solution to the issue. And you said that they resulted in a lot of conflict resolution, but I was wondering if you could just briefly expand on what it is you mean by conflict resolution and what exactly that looks like in that context. And then a second question was for the third presentation. So you were talking about, you're mostly referring to women being, having improved access to contraception in this way that you're talking about, which makes sense. I think in a lot of ways, women are the only ones that are taking on the work of reproductive fertility control. And I was wondering if you had, if you could expand on maybe possible benefits that you might see for male adolescents in making telecommunication or contraception via telecommunication more accessible to individuals. Thanks.
So yeah, thank you for your question. Peace huts are a really interesting and promising direction for addressing this problem. So they were established by a network of basically private citizens, women, following the conflict as a way to resolve many kinds of disputes. So it could be property disputes or family disputes or really all kinds of local disputes. And they involve small groups of women mediating any kind of dispute. So it's a promising method for lots of different kinds of issues, but we've seen that it especially there's a high proportion of disputes that involve gender-based violence. So women played a very important role in resolving the Liberian conflict, and this is an outgrowth of that it's a way for women to really be involved in how these disputes are mediated and be aware of the issues that are involved in gender-based violence.
Hi, thank you for your question. So in one of the slides that I showed, I had the CDC study where it showed that there was a percentage of younger people that felt like they never had time alone with the doctor, and then also that they were worried about their confidentiality, specifically with regard to their parents finding out. And in those two figures, it also included males, and it actually showed that males also feel similar to women. Males also feel like these concerns that their parents are going to find out, so they're just as aware of this possibility. And I think a benefit of also really speaking about contraception with reference to men is that it's increasing their safe sex, and it'll reduce the spread of STDs, and also it's equally important for men to be aware of like what can cause pregnancy, how to prevent pregnancy, and so contraception in men would help that as well.
Well, thank you. We're going to have to wrap up now, but please feel free to continue to engage our panelists during the reception period that's going to follow. And we're going to do the open mic session right now. So if you all would like to take your seats. Thank you very much.
Hi, everyone. We're really excited now to have a different type of format. This is the hot topics for interesting and engaging work that's being done here at Georgetown and the broader DC community related to gender justice. So we have a number of invited hot topic speakers, and then we will open it up for all of you to contribute some of your ideas. And like the other moderators, I'm going to keep us on time. So first, let me start. My name's Christy Graves. I'm in the Department of Oncology, and I'm privileged to serve as one of the co-directors for the Gender Justice Initiative. And the format will be the hot topic speakers say their name, where they work, and then a few key highlights about the work that they're presenting and engaged in. And then this will then set the stage for deeper conversations during our reception. So we have 7 specified hot topic speakers. I will call you up, and maybe you can come to the front, and I will keep us on time, and then we'll move on from there. So our first presentation is by Vanessa Gilbert and Dion Coker-Apia.
Dr. Coker-Apia is right there. Oh, thanks. Hi, my name is Vanessa Gilbert, and I'm the Community Engagement Manager for the Davis Center of Performing Arts and also the Theater and Performance Studies program here at Georgetown. And I've been in my position for exactly 8 weeks. Trying to represent gender and justice. I'm here particularly, first and foremost, to promote a pre-show conversation that Dr. Coker-Apia and I will be leading around a performance that you may have seen something about. It's called Our Class, and it's running at the Davis Center, just opened last night, and runs through November 17th. I have some materials for all of you with a discount code if you would like to join us. The play follows 10 people who were children in 1926 in a village called Jedwabne, Poland. 5 are Catholic, 5 are Jewish. 3 are women, 7 are men. In the span of their lifetimes, and the play runs from their time when they are 5 to the time when the last living are about 95. Germans invade Poland, Soviets invade Poland, Germans invade Poland again, Poland becomes a country. All of the tumult of the 20th and early 21st century is represented in the play through the bodies of these 10 people. And in particular, there are, as you can imagine, the travesties of World War II, but also some pretty intense depictions of domestic violence and neighbor-on-neighbor violence in a rape and then in a massacre, just so you know. And our pre-show conversation on Thursday, November 15th, in the Gonda Theater lobby at the Davis Center at 7 p.m., free to all, is going to really focus on what it means to be a student taking on the physicality of the 20th century. So we'll be joined, they both, Dr. Coker-Appia and myself, we're joined by the assistant choreographer of the play, who can talk about the process of staging these violent scenes, and also by a graduate student who's undertaken a lot of bystander training. So I think it's an interesting question, sort of what is the, how do we stage violence when we live in such a violent world? So please, I'll leave these out for you. Thank you so much. You can also get a trading card with one of the characters on it. Thank you so much for your time.
Mr. Chris Parker?
Start my clock. Hi, I'm Chris Parker. I'm an assistant professor at Penn State and in the business school and adjunct faculty member here at McDonough. And I want to talk to you today about discrimination, more broadly speaking, bias more broadly speaking. Ride sharing, Uber, Lyft, those types of things, as soon as they see your name in your profile picture, people of color, women, other people who signal support for a social cause, in the case that I deal with, the LGBTQ+ community, have higher cancellation rates. That's the whole topic of my research. To do that, we called 1,600 rides in our cities, or our nation's capital, and over the course of 4 weeks. And the only thing that was a glimmer of hope in my eye is that I actually observed no major discrimination against women, but I do see major discrimination against people of color and people who signal support for the LGBTQ+ community by adding a rainbow filter on their profile picture. I'd love to talk more about it later.
Way to stay on time. Thank you so much. And you can convey a lot of really interesting information in a very short amount of time, so this is terrific. Gina Bennett?
Hi, my name is Gina Bennett. I'm an adjunct faculty member in the Security Studies program where I teach ethics and intelligence. But by day, I'm a 30-year veteran of the CIA. I've been in counterterrorism my entire life. I still am. I have a few more years before I can finish that. My topic is I want to promote the interdisciplinary study of how the Me Too movement and national and international security can combine forces. I myself am a survivor of the word we don't like to use, which is incest. And because of that, I wanted, and what I have done for my entire career in terms of counterterrorism, I have learned that I have been putting my life on the line for 30 years in support of this idea of national security that is completely false, because women are not secure. In fact, I think women in the United States, we're higher than the global average for intimate partner violence in the United States. And it's actually more lethal because of access to weapons. At any rate, my point, though, is really trying to infuse national security and the concept of it in this country and elsewhere with resiliency that I think only survivors of this type of abuse can really understand. We don't wait for somebody to rescue us. We survive and we preserve the essence of who we are even when we know we cannot keep the safety of our physical being. So that's really what I want to try to imbue in a national sense. Thank you.
Thank you so much. Edward Joseph Ingesbretson is he here with us? Yes. Sarah Thompson?
Hi, I'm Sarah Thompson. I work for Georgetown's Institute for Reproductive Health in DuPont Circle, and I'm here to talk about our work combating gender discrimination and son preference in Nepal. Gender disparities, especially son preference, continue to persist because of many cultural and religious norms that are complicated by financial hardship and men migrating out of Nepal for work for large periods of time. If a woman does not successfully produce a male heir, she is often blamed and could face social pressure, intimate partner violence, divorce, forced abortion, and to continue to have as many children as it takes to finally give birth to a son. The Pragati intervention utilizes community games to teach about fertility and to combat harmful gender norms. The son-daughter game we was developed to educate community members about the role of female and male sperm and eggs in self-determination and sex determination, and how ultimately it is the male chromosome that determines the sex of the baby. The game not only facilitates communication in the community and between couples, but also highlights how sun preference devalues women, puts unfair pressure on wives as well as their husbands, who could feel socially pressured or emasculated with not having to produce a son. If you'd like to hear more about this game and how it's being turned into a mobile app in Nepal, feel free to talk with me about the panel. Thank you.
Vladimir Mukovyarov.
Thank you. Hello, I'm Vladimir Mukharlimov. I'm an assistant professor of finance here at McDonough School of Business. So I do work in corporate finance. Part of it is in venture capital. And so one of the projects I'm working on explores the male versus female performance in the venture capital industry. So surprisingly, we found that female venture capitalists appear to be less successful than their male counterparts. Then we decided to dive deeper. And so what's key is that when their colleagues become more successful, the success of men increases, but the performance of women stays constant. And so why is that? In venture capital, informal mentorship is very common. There is a ton of events on which partners have a chance to bond with each other, influence each other, and ultimately help each other become more successful. But since venture capital is such a male-dominated industry, unfortunately, women have been excluded from a lot of those events, especially in younger and smaller firms. But in bigger and more established firms, where there are formal systems and processes in place, there is emphasis on formal mentorship that applies equally to men and women. And in such firms, women do get a boost when their colleagues become more successful. And in such firms, in bigger and older firms, women are just as successful as male venture capitalists. And so this study gives some support to the idea that formal systems are important when it comes to creating a level playing field for everyone. So this is my research.
Thank you very much. Thank you. And is Mindy Coulter here? Excellent. She traveled way across town.
I felt this important. Actually, there's a movie going on, which on the other side of campus that I interrupted to come here. My name is Mindy Cutler. I run a little think tank called Asia Policy Point. We work on the intersection of history and security, and one of the issues that I'm infamous or famous for and work a lot on is the comfort women issue. Women, girls, and boys who were sex slaves to the Japanese military during World War II, before and during World War II. And this has become a hallmark policy of the Japanese government to deny in every shape and form that this ever happened, though that flies in the face of witnesses and documents and such like that. And what is interesting is this is an issue that would explain to you, if it's not resolved and solved early on, it will continue to fester 75 years later. And and it goes over on the idea of what is women's agency, what control do they have over their body, the patriarchy both in Korea and all the other countries, because the Japanese want to keep this to a Korean-Japanese problem. No. There were white Western women, French, Russian, Dutch, and Americans. There were missionaries. There were Indonesians. Wherever the Japanese military went, there were women that were trafficked, and then there were women of opportunity. There is a film festival this weekend, starting tonight, and on Saturday and Sunday. I hope you will come. I hope you will look at my website, and I have an article a number of years ago in the New York Times, and it's not a history issue. It's a now issue.
So one of our Hot Topics presenters has the flu, and so out on the table in the back from the National Academy of Sciences, our Georgetown Dr. Liza Gold in the Department of Psychiatry was a member of this roundtable for the National Academy, and they put out a report, and it's a very strategic and hands-on document for interventions for preventing sexual harassment. So please feel free to pick one of these up and spread the word on these very specific and evidence-based strategies. And now we have a few moments to open it up for members of our attendees, if there are any additional hot topics that anyone would like to present.